All right, this is part two in a series of videos on exploring the physical demands of running a needs analysis and understanding what the human body needs to, the prerequisites are before we get someone back to running at full capacity. And in this video, I'm just going to use what evidence that currently exists. There's a plethora of it around the knee. And I'm going to use a case example to kind of set the stage because it's going to frame how we consider the necessary prerequisites for running for each of the other joints, that is the ankle as well as the hip. Okay, so when we're looking at the industry standards for returning to running, we'll use the knee as our exemplar simply because there's the most information that has come out regarding that, particularly around ACLR. That being said, oftentimes that criteria is extrapolated and utilized for other pathologies as well, not only at the knee but also at the hip and the ankle, which we'll talk about that criteria. But if we're thinking about a clinical case that I'll present here in a moment, let's just ask ourselves first, like, what would the industry guide, how would it guide us as far as best practices? So here's a survey that was done internationally for physical therapists, and for your clinical assessment across the Netherlands, Australia, as well as France. You can see the criteria listed in the columns there, and then the essentially clustered horizontal bar graph showing where the consensus was highest. Specifically, they would expect or they would recommend that time since injury, the overall ACLR RSI, which is someone's psychological readiness for return to sport, swelling and pain, and then clearance by surgeon really make up your top 5. So when we look at that same study in regards to the physical and performance-based tests that are recommended by physical therapists across this international survey, we see that single leg squatting would be second, knee extension strength being number 1, and then drop vertical jump being number 3. Close in that fourth category, fourth or fifth criteria would be our knee flexion, that is hamstring strength, and then also hop testing. The overemphasis on the knee extension strength versus the hamstring strength really, I think, is explained by the muscle's role during running, where the quadricep is going to be the muscle that predominantly works eccentrically to kind of buffer and shock and load attenuate, thus protecting the joint more so than the hamstrings, even though it would be good for there to be adequate muscular balance around the knee joint. So if we take the industry standards as far as the specific tests and assessments that are recommended, what are the said criteria for said tests? Okay, so a seminal study was Rambod in 2018 when they did a systematic review as far as the criteria that would be recommended for returning to running post ACLR, and their recommendations were that it should be time-based with a median of 12 weeks. An early onset initiation of running would be 8 weeks, with a more protective focus being at 16 weeks. Clinical examination, knee range of motion, pain, knee extension, and effusion, they should all be full range of motion or greater than 95% of the uninjured limb. Pain should be less than 2 on a visual analog scale, full knee extension, and no effusion. When we're looking at strength, so you want at least 90 or at least 70% from the other limb. And for the quadriceps and hamstrings respectively, you would want close to over 70%. One study did denote an 80% strength limb symmetry index. For performance-based testing, similar to what we saw on the last slide in the last survey, this just gives us specific criteria. So hop testing LSI, if you're going to incorporate that, should be 70 to 80% limb symmetry. Y balance can be considered. There should be a proprioception LSI of 100%. And functional tests such as your 10 single leg squats to 45 degrees without loss of balance, would be 70%, whatever your metric is. Maybe it's your knee varus or valgus, or number of repetitions. There's also 30 step and holds without loss of balance that also is more of a qualitative assessment and coordination movement pattern. Normal gait pattern would be recommended. What is normal? I think that also is somewhat ambiguous, given the fact that a lot of clinics don't have the 3D motion capture or even 2D motion capture to really quantify this. It's going to be more subjective to the eye of the beholder of the therapist, and where we know that the human eye captures 30 frames per second. Really, in order to be able to adequately and accurately assess someone's at least running gait, it would be recommended that you have 240 frames per second. So a video analysis would be necessary. It's not really specified here whether they're talking about a normal gait being just walking or with running. A recommended approach, using a time-based criterion plus strength and performance-based assessments that are individualized with the decision making would be recommended. So keeping this criteria in mind, let's take it to our clinical case. So our clinical case is a male who's 39 years of age. He has no pain or knee effusion. He's greater than 6 months out of a meniscectomy. Full knee extension with knee flexion greater than 90% LSI, quadriceps and hamstring strength greater than 80% LSI. Here's his testing results of an isometric test for quadriceps on an isokinetic dynamometer done at 90 degrees of flexion. You can see that he's producing really good forces relative to body weight, with a peak torque to body weight percentage on the healthy limb at 91%, and then the involved limb on the right, he's at 71.9%, and that would put him at an 80% limb symmetry indices for his quadriceps. His hamstrings were even more superior than that in regards to their limb symmetry. 3 months progressive strength training is what he has undergone. He's performed single leg step down greater than 10 repetitions with good form, and able to perform low level plyos, which include jumping on the spot, double limb, single limb, side to side, double limb, single limb for multiple repetitions, and then also forward and backwards. And he's performed this for twice a week for 2 weeks, so 4 sessions total without any repercussions. So I think based off the industry standard, it would be recommended that this individual would meet the criteria necessary for running. So if we go ahead and look at his gait, and I'm really going to try and make an argument for the importance of considering our movement analysis, as well as the incorporation of rate of force development, essentially someone's muscular power rather than just their strength. I have 2 videos here of a individual running on a treadmill. Note the date of when it was taken, January 10th, 2024. So there's a right-sided view, and then we'll also look at the left-sided view. And yeah, what I would encourage you to try and discern is if there's any deviations from one side versus the next. Start up the other side as we look at that. So from the left, again, looking at joint angles at the 3 major muscle groups. Consider the vertical oscillation as well. So if you look at the video on the right, we'll use that as an exemplar. Look at the waistline as to how much it oscillates from one limb to the next. So as he lands on his left, his shirt sinks below the edge of the treadmill, versus on the right it stays above. That also corresponds with the knee flexion angle that we see. and the amount of what they call joint excursion, so the amount of knee flexion that he gets from the initial contact to mid stance. On the right side, he's quite stiff. The knee doesn't really go through any excursion from the initial contact to mid stance, versus on the left, you can see he hits almost with a straight knee, and then he lands very compliant on that. All right, so we'll move forward, but keep this in mind, not only the date and the deviations that we see. So a big shout out to Dr. Rich Willey, who is a giant in the field of running. He runs the University of Montana running lab. This is an image directly from a September 27, 2022 post on his Instagram, Mountain Running Lab. And I encourage you to follow him. He puts out some extremely good content that is educational, informative, science-backed, and I think also really visually easy to comprehend some of the difficult, complex concepts that he conveys. So I'm going to use this as an exemplar to demonstrate that individuals post ACLR, and we're going to use the ACL reconstruction patient as an exemplar for those individuals that also have other knee-related conditions and pain, because they demonstrate comparable deviations with their running, and in this case, individuals post ACLR underload their knee, and we see this with the stiffened gait as we saw in the previous video. The things that you can see from the left versus the right, the left being the injured individual rehabbing or coming back from their ACL reconstruction, the right being the healthy control. You can see that the knee flexion angle is less on the left side. Again, they're underloading the knee joint as well as the quadriceps. That leads to the two things, one or maybe three. So one, it leads to an underloading of the quadriceps and thus continuing to perpetuate the quadricep weakness over time. Quadricep strength is a wonderful vital sign for how healthy your knee is and will become. Secondarily to that, it underloads the cartilage, which is necessary in order to maintain healthy homeostasis. Specifically here, we're talking about the patellofemoral joint. That is where your kneecap interacts with the femur. You can see also that the knee joint center is much closer to that red line, which indicates that the amount of torque that's going through that knee joint is less compared to what we see on the right. Additionally, you can see that the ankle center joint is much further away from the red line compared to the one on the right, indicating that the load shifts not only up but also down the chain to both the hip and the ankle. And so with running, we get worsening patellofemoral joint osteoarthritis over time, which is a problem. A lot of these individuals that are accruing these knee-related injuries, particularly ACLR, are younger, and so it's really devastating that within a 10-point time point, they have a 6-fold increase in their osteoarthritis. Depending on the study and the research that you follow, but regardless, we know that they're at an increased risk. When we subsequent information that's, I think, for me, really impactful and keeps me up at night is even with individuals that are going through a stiffened knee gait with walking, they have associations of synovial fluid and osteoarthritis biomarkers. So there's been a strong correlation to show that individuals that come off their crutches and or their brace and in their attempts, with best of intentions and goodwill, they're trying to just walk normally and get back to their lives. And again, they're as therapists and sports medicine professionals, we need to be part of the solution rather than part of the problem. It's not okay that they're walking around with stiffened knee gait. This is associated with, you can see the SF, which stands for synovial fluid for the interleukin-6, which is an inflammatory marker. So they're taking the fluid directly out of the knee joint, and this would be an increase in the interleukin-6 is something that you see in individuals that have osteoarthritis. Secondarily to that, you also have the serum C2C, so this is taken out of the blood, as well as the serum MMP3, which is the matrix metalproteinase 3. These are biomarkers associated with cartilage degeneration and remodeling, particularly in the context of osteoarthritis, and are important for joint-related health. And so if they become elevated, this is, again, the early signs of the changes that are going to promote a cascade of events that leads to the early osteoarthritis. And again, this is with individuals with walking. So individuals demonstrate altered gait patterns even with walking at faster speeds, even at slower speeds, but can be augmented with faster walking. And as we saw in part 1 of our video series, is that at the knee joint, when you go from walking to running, that there's a 5x increase in the patellofemoral joint stresses. So if we're already getting early onset biomarkers with our walking gait, and their individuals are walking around with an antalgic and stiffened knee, it's a problem, not just because of the secondary compensations that occur within the musculoskeletal system, because it is one of the early movement vital signs that is going to be an indication and lead to the degeneration of the knee joint over time, which then compromises quality of life, autonomy, agency, and then eventually can subsequently lead to secondary non-communicable health-related diseases. Yeah, so it's a problem. It's something that needs to be addressed, and yeah, we're seeing it in the running, as I showed in the previous video. But we need to even take a step back and consider it for the gait as well with walking. Okay, so quick orientation on the y-axis. You have the negative work in joules per kilogram, and then running across the x-axis is time post ACLR in months. So you have the pre-injury state, the 4 months, 6 months, 8 months, and 12 months. And then there's going to be 2 bars that populate. So the first bar that does not have the black lines, the black diagonal lines across it, is the injured limb. And then the bar or within the clustered histogram that has the diagonal black lines is the injured limb. You can see in the white is the negative work or the shock absorption that is done for the hip. The light gray is going to be the knee, and then the darker gray is going to be the ankle. So if we look at how the different joints uh, are affected by the ACLR uh, and across time, we can see quite dramatically that the knee is most significantly affected with a stiffened knee gait pattern where there is a little joint excursion, which is uh, expressed as the reduction in the negative work that is done during the running, uh, during the stance phase of the running gait. We've previously established that even with individuals that are walking with a stiffened knee gait post ACLR, that this can be caustic to the knee joint, showing biomarkers both within the synovium of the joint as well as in the blood, that this will potentially lead to early onset of osteoarthritis. Now that the forces are even further exponentially increased due to the higher rate of loading and the associated flight phase of running as compared to walking, that this would only further be detrimental to the knee joint and promote a lot of the osteoarthritis biomarkers that are seen with walking. And as we track this across time, we can see that it's persistent. So in this cohort, uh, even at a year out, that time in itself just does not normalize the negative work that is performed. In fact, there's a shift. As you can see, there's a gradual increase in the shift as far as the ankle shock absorption, a fluctuation in the hip depending as far as like the amount relative to the pre-injury state that fluctuates from what regarding the time point, right? So be it 6 or 4 or 8, the hip seems to fluctuate a little bit, but definitely a stiffened pattern within the knee joint that's not restored at a year out. So running knee flexion angle post ACLR. On the previous slide, we looked at the negative work that was done, which correlates quite strongly with that of the knee flexion angle. This is something that's a little bit more easily observable and more clinically friendly and relevant. So in the running image, on the injured limb, you're looking at a knee flexion angle of 34 degrees versus the healthy limb, their knee flexing to 48 degrees. So you want a greater sagittal plane knee flexion angle during the stance phase. Here we see that the stance phase knee extensor impulse is 27% less, which is also associated with that 14-degree difference in the max knee flexion. Once again, you can see this graphed across time. So on the y-axis here, instead of the negative work, you have the surrogate measure of peak knee flexion. You have the surgical limb in black, the non-surgical limb in the light gray, and then you're looking at peak knee flexion during running post ACLR across time. Once again, you have the 4, 6, 8, and 12 months, and comparable to that of the loss of negative impulse that was seen on and negative work that was seen on the previous slide, that correlates very strongly with the knee flexion angle. So it's not okay that people are coming off these injuries and walking with a stiffened knee, and it's certainly not okay that they're doing so with their running gait as well. And it's not we can't run under the assumption that just allowing this to occur across, just letting time transpire is going to fix it, because it's clearly that's the data would suggest that it doesn't. And this in itself is enough to cause the increased risk factor of knee osteoarthritis moving forward. And that's what we see at the 10-year mark, where people are at a significant increased risk as compared to their healthy cohort, as well as to their opposite limb. So the take-home message here is that strength is good, but power is better. So individuals with greater than 90% quad rate of torque development limb symmetry index had an average of 27.4% greater knee kinematic symmetry than those that had a lower than 90% limb symmetry index on their rate of force development. For every 10% decrease in rate of torque development, LSI, there is a 0.9 degree decrease in the knee flexion difference during running. And for every 10% increase in the rate of torque development limb symmetry index, there is a 3.5% increase in knee flexion symmetry during running, i.e. this is an enhancement in the symmetry in the knee extensor moment. And so on the y-axis here, we have the knee extensor impulse, the limb symmetry index, and then we have the quadriceps performance running across the x-axis. The rate of torque development is shown in the lighter gray, and you can see that it has a stronger correlation with the knee extensor impulse than does the quadriceps strength, and is a better predictor of what their impulse actually is because of the more linear correlation that you see. So if you drew that dotted red line at 80% knee extensor impulse LSI, suggesting that that would be an acceptable amount of symmetry that would potentially be less detrimental to the joint, then we could say that that would correspond with an individual getting their rate of torque development symmetry also to about 80%. That being said, when someone's quad strength is at 80% or even at 90%, they're still well below that threshold bar of knee extensor impulse. Thus, they're still likely running with a knee straight or stiffened position, and they are not properly shock absorbing through their knee like they would naturally do in their pre-injury state or on their other limb. This is a slide from Dan Kobian from CSM 2023. It's a little bit faint. I apologize. It is a photograph. And so on the let's look at the first graph on the left. So we have running knee extensor impulse, limb symmetry index going from 0 to 120%, and then running across the x-axis is the quadriceps rate of torque development LSI. And it's important to note how the rate of torque development is quantified here. So there's different metrics, and the first you can take rate of torque development at as a slope or instantaneous. You can take it at 100 milliseconds. You can take it 200 milliseconds. The way that they do it at the University of Wisconsin is they look at rate of torque development 2080. Specifically, they look at the amount of force that is produced between the time interval that is taken between their peak force curve at 20% of their max and 80% of their max, and divided by the time interval. And that's how you're getting the quantification of the rate of torque development, and then you're looking at that from side to side. So if we're interpreting this graph, so you can see the yellow shaded bars, just with the red bar kind of indicates the lowest threshold of acceptability of the knee extensor impulse, such that the individual is starting to load their knee well. Then where does that kind of correlate with the acceptability of rate of torque development? So at least 70% LSI of their rate of torque development would be recommended in order to ensure that the individual is adequately loading their knee appropriately and not landing with a stiffened gait. That being said, 100% is better. And if we draw that line, because if we measured the rate of torque development, we held the individual to 100% side to side limb symmetry, then we could say that nearly all of the individuals at that rate would be able to have a more symmetrical impulse over 90% from side to side. That being said, when we look at this, not so much from a limb symmetry index, but when we look at the rate of torque development relative to the body weight. In the second figure, you have running knee extensor impulse, same as you did on the first graph. The x-axis here is the involved limb rate of torque development, and it's quantified by Newton meters per kilogram per second. So they've normalized it now to the body weight of the individual. That this is at least, you would want at least 9 millimeters per kilogram per second. But if you have 12, that would be better, because a much larger percentage of the individuals would be above that 85 to 90% LSI for their running knee extensor impulse. If you wanted to quantify this from the metric units to the imperial units, you would simply divide by 3. So if you're going to measure someone's rate of torque development 2080, then you're going to, and you divide it by their pounds of body weight, it would be at least 3 foot-pounds per pound per second, and a better cut point would be 4 foot-pounds per pound per second, in order to ensure that their knee extensor impulse was sufficient. So if we revisit now our case study, as I alluded to, that his LSI was greater than 80%, or at 80% isometrically, strength relative to body weight was 70%, and I had expressed the other criteria that he had also met on a clinical standpoint. That being said, when you look at his rate of force development, this in itself explains the deficits that we see in the inadequate knee flexion and joint excursion that is shown with the videos. So the involved limb on the top row, healthy limb on the bottom, you can see the rate of force development at 2080 relative to body weight, so foot-pounds per second per body weight. On the involved limb as 2.2, it's shy of that 3.0 that we spoke about in the previous slide, and his healthy limb is close to that 4.0, which would be optimal. Moreover, beyond just that, you can see the LSIs for his rate of torque development 2080 being at 56%, his rate of force development at 200 milliseconds being at 68%, and then his peak torque limb symmetry index being at 80%. So it would suggest that this is a prime example that power is more, strength is good, but power is better. Is the short story, and the power metric that you look at also matters. You can see that the rate of torque development or rate of force development at 200 milliseconds limb symmetry is much, a meaningful margin higher than that of their rate of force development at 2080 at 56%. So my argument and my point being is, yes, we can have all these criteria that the industry would recommend, but yet even despite having this criteria available to us, our patients are still experiencing an increased risk of osteoarthritis at a 10-year time point following their ACLR and other knee surgeries. And I think that looking beyond just what criteria currently exist, I think that muscle power is important. I also think that it's critically invaluable to be able to do an adequate running video analysis, to be able to really ensure that the individual is adequately flexing and going through joint excursion and shock absorbing to protect their joint. I would also make the argument that as of right now, it's kind of been trial and error, the establishment and or expert opinion, the establishment of these criteria for return to running. And really, I think the better strategy would be to look at the specific physiological demands at each joint for running, and then base our criteria off that rather than on a trial and error approach. We are much more advanced in that in our scientific methodology, and so our clinical practice should also reflect that. So sticking with the knee, let's look at the the physiological running demands of the kinematics of the knee during running. So the column headers, you have the different speeds of running because they're the kinematics of the joint are going to be dependent upon that. I've listed them off in miles per hour based off the study that is cited at the bottom, Ordendorff, 2018. And then in the row headers, you have knee extension, knee flexion, and then the overall joint excursion. So you would see that at initial contact, the individuals slightly flexed at anywhere between 12 and 13 degrees with a faster running speed associated with more knee flexion at initial contact. Knee flexion angle is going to be around 42. Again, as speed increases, the range of motion demands are going to also increase, and then the joint excursion is also going to increase as well. And so to give a visual representation of what we're talking about with the initial, joint excursion, it's taking the initial contact and then looking at the stance to that of the stance reversal at the point of greatest knee flexion. Now, the joint excursion here is less than what you see in the table. Specifically, you can see going from 149 to 139, that would be a 10-degree joint excursion from initial contact to the mid stance or greatest point of knee flexion. That being said, you can also appreciate the fact that this individual is striking not on his heel, but more on his midfoot. Thus, there's going to be a greater attenuation of force through the ankle joint, where he's going through currently almost 17 degrees of joint excursion because he's in slight plantar flexion, and he's going to 80 degrees of dorsiflexion, which would be 10 degrees of dorsiflexion. But these were the point of the picture in the images are really to give you a visual representation of what the knee angles in the table represent and the points during the gait at which they represent. So it's good to keep in mind that what we would expect to see from our knee range of motion, our kinematics. The other two variables, right, are going to be the kinetics, specifically the force. Like what is the actual force that is needed in regards to body weight with running at the knee, and then also what is the power that is represented or necessary. So the running demands for the kinetics at the knee joint, specifically the quadriceps and the hamstrings respectively, are shown here. So when you equate the Newton meters per kilogram in regards so that's normalized to body weight for knee flexion and extension moments, you can see that for knee extension, depending on the running speed, that you would need anywhere between 73.5% of body weight up to 90% of body weight the faster that you run. And then knee flexion would be just a fraction of that, again, just speaking to the different roles that the muscles play during the act of running or the task of running. And so this gives us good guidance that really we should be expecting the quadriceps to be able to produce anywhere between 73 to about 90% of body weight, and that should guide our thresholds and our criteria rather than just whether someone can be successful at performing said running gait. This I think would be a more specific and better rationale than just taking industry standards at face value. Yet, as we've made the point, hopefully, that what matters more than strength is power. And so muscular power should be considered if we are going to try and ensure that someone's knee extension impulse and their sagittal plane knee flexion angle is going to be in an acceptable range of 85 to 90% limb symmetry. So the knee joint power, you can see the concentric knee extension torque or rate of force development, foot-pounds per second per pound body weight is shown for the different running speeds. And then you can also see the knee extension for the eccentric. Obviously, the eccentric being more important than that of the concentric because that's the the muscle function that is protecting the joint during the loading during running. You can see that these numbers correspond pretty readily to what we had spoken about, with anywhere between 3 to 4 foot-pounds per second per body weight being what is recommended. So the eccentric values are directly in line with the University of Wisconsin's recommended RTD 2080 normalized values. And to ensure that 80% LSI in running knee extensor impulse post ACLR, but using that diagnosis as well as the knee criteria as exemplars that can be extrapolated to other diagnoses and other joints, which we will do here in a moment. So the testing criteria, so often I find that knee extension rate of force development is something that's not commonly tested, and the industry criteria would otherwise suggest or reinforce that. Oftentimes you want to do this, I think it's necessary and mandatory to do it isometrically in a seated position, 90 degrees of knee flexion, 90 degrees at the hip, and then the sets and reps should be 3 sets of 5 seconds. The running ideal cutoff would be 3.0 foot-pounds per second per pound of body weight, as discussed, and then the outcomes, torque per second. Again, you could take the rate of torque development at the different time points. I think that the rate of torque development metric that corresponds more readily to someone's knee flexion angle is going to be the RTD 2080 normalized to body weight. And then if you are going to utilize the 100 and 150 milliseconds, it's important to prospectively establish like what your time point zero is, and your rate of torque development. Time point zero is when the resting torque exceeds the toe peak. That's you were talking about the time force curve. Once that time force curve exceeds 2.5% of the resting torque or resting load, that would be your time point. That data point would be your time point zero. Without going too far into detail, but the sampling rate of whatever machine that you're utilizing should be high. It should be at least 100 hertz. That is 100 samples per second. And there are devices on the market these days that are not isokinetic machines that can do sampling rates up to 1,000 hertz. So it is becoming more readily available and affordable, and I think it should be tested. To follow up on that point as to what equipment I think would be recommended in regards to testing someone's muscle performance, regardless of what muscle group we're discussing, I've highlighted the 5 muscle groups that I think are going to be most important for running, which are the major muscle groups of the lower extremity, which include the glute, that is the glute max, the glute med, the quadriceps and hamstrings that we've discussed extensively, and then certainly the lower leg, that is the gastroc and soleus complex. Certainly other muscle groups play into it. We can talk about foot intrinsics, which we will, and as we discuss the other joints that are necessary for running criteria. But without getting into that discussion at the moment, let's just talk about the methods by which and the tools that are necessary in order to be able to adequately assess someone's readiness and to make meaningful and evidence-based decisions of someone's readiness and clearance for returning to running. So we have the isokinetic is the gold standard. In our good category, we have a fixated dynamometer with a time force curve. Ideally, the sampling rate, if we're going to get rate of torque development, needs to be 100 hertz per 100 hertz or 100 samples per second. Our force plates can do the job, but they are somewhat limited to certain muscle groups, most notably the plantar flexion. You could potentially make the argument that you could do it for knee flexion depending on the setup, but typically it's going to be more an isometric rig setup for your plantar flexors. Acceptable would be your fixated dynamometer without a time force curve. Again, it doesn't give you rate of torque development. It does give you the peak force. You could also use a pole gauge and or crane scale for your sufficient category. You're looking at field tests such as a knee extension and or flexion machine that you would find at your commercial gym. Again, these are surrogate measures that are sufficient if you have nothing else. What is insufficient is manual muscle testing. Though it may have its role in screening and triage and determining neurological deficits, it can miss up to a 20% strength deficit from side to side, and certainly it would be very difficult to quantify someone's strength relative to body weight with it, and thus it really can't be endorsed as having a meaningful role in determining someone's readiness and criteria necessary for running. So let's put some operational definitions to what I mean by gold standard, good, acceptable, and so on. So the gold standard, anything that falls within this could also accompany the isokinetic dynamometer in that category. So it needs to be good reliability and validity. We'll use the ankle as the example here. So all ankle directions, all angles, and all speeds can be tested. All muscle performance constructs can be quantified. For your good category, the measurement tool needs to have good reliability and validity. All directions, all joint directions, except for the force plate, which is somewhat limited, as I alluded to in the previous slide. All joint angles can be tested isometrically. Time strength curves are available, thus you can get rate of force development, as well as looking at the normality of someone's force curve profile. So looking for force oscillations, looking at acceptability in regards to the reliability and the validity. All joint directions, again, isometric only here can be utilized with these different tools. No time force curve would be available, unfortunately. And then for the sufficient category, it's acceptable reliability. The validity relative to the gold standard would be in question, though it may correlate with what your isokinetic dynamometer force would look like. It likely will not give you the same quantifiable metric or value. I give the example of testing someone isokinetically at 60 degrees per second knee extension. You'll likely get a different torque output than what you would get if you were measuring someone on a commercial knee extension machine, and that has to do with several factors and differences in the type of testing that is being done, and then also with the mechanical pulley system within the field-based test. And then the acceptable reliability but unacceptable validity. So isometric only, all joint directions is available, and it's easy to administer, but it really doesn't have utility, and I can't really endorse it. That is manual muscle testing for determining someone's readiness to run. So in summary, return to running criteria, the industry standards. This is a little bit more robust than what I presented in summary from the Rambaud article 2018. So pulling together multiple resources here. So the clinical criteria, pain should be less than 2 out of 10. It really shouldn't be present. No effusion or trace. Knee flexion and should be greater than 95%. Full knee extension. Muscle strength criteria, we've gone through this extensively thus far. So quad strength, the industry would recommend greater than 70%. I think that it needs to be higher than that. As I alluded to with the correlation graphs, that even at 90% LSI, that they're still in question as to whether someone's knee extension moment is going to, during running, is going to be acceptable greater than 80% from to the other side, or reestablished to that of prior level of function before the injury. Quad peak torque to body weight is going to be a better metric. Again, we know that when we looked at the actual running demands, that greater than 70% and up to 90%, depending on the running speed, is necessary for someone's force production. I know the units here are in metric. You can simply divide the metric values by 3 to get your English units. So your 21 or your 2.1 Newton meters per kilogram would equate to 70% of foot-pounds per pound of body weight, as we saw that even at 5.8 miles per hour, which was the slowest running speed that was investigated, that you still needed 73.5% of body weight. So that 2.1 is still kind of low, but certainly better than the 1.45 Newton meters per kilogram that has been touted. This is the criteria that we've really emphasized in this conversation, has been the 3.0 foot-pounds per second per pound of body weight, and greater than 80% LSI for their knee extension rate of torque development would correlate with a greater than 80% knee extension moment during their running gait and their sagittal plane knee flexion angle. Other criteria that has been utilized as well has been your single leg press, seated calf raise with tested isometrically, typically with a force plate 1.5 times body weight. That's from O'Neill in 2019, and then heel raise endurance. Because we haven't gotten down to the criteria for the ankle, but you'll see that these also become relevant. These are criteria that have been recommended even post ACLR because there's other muscle groups that also need to be sufficiently conditioned and have sufficient capacity in order to be able to run with a protective and healthy gait pattern. I think the functional performance-based criteria here is really important, and something that is also emphasized within our discussion has been the qualitative performance of single leg squat, single leg landing, and gait pattern in particular. Looking at that sagittal plane knee flexion angle, I think is super important, as I've alluded to, because that even just with a stiffened knee gait pattern with walking that is associated with increased osteoarthritis biomarkers, both in the joint itself, but also within the blood serum, suggests that they would only further increase and be augmented with the act of running with higher impact loads. And then quantitative base, being able to land repetitively on one leg to evaluate single leg landing capacity would be recommended. How many repetitions here is somewhat in question. Harrington et al. In 2013 recommended 30 repetitions. But again, with running, it's going to be a lot more foot contacts than that. Patient-reported outcomes should be considered. IKDC has been described greater than 64 out of 100. Time post-surgery, that 12 weeks has been recommended as a median. That being said, likely not long enough. Rarely are people, at least in my clinic and under my exploration over the last better half of a decade with my clinical practice, are meeting that. That could be on me, I don't know, but when I'm speaking to other colleagues within the field, they also seem to recognize that people aren't meeting those the clinical criteria, the muscle performance, and the functional performance-based criteria within that 12-week mark. Training load criteria, so include a progressive running preparation period before starting to run is recommended. Skipping, low-level plyo variations can be a good loading stimulus to prepare an individual for the return to running. And so this conversation thus far has really emphasized what is the criteria, the physical demands and capacities that are necessary at the knee joint. That being said, running is a multi-joint, full-body endeavor. So what are the criteria that we can consider for the other joints around the lower extremity? And we're going to use a similar framework because it seems to be that the kinetics, the kinematics at the knee that are extrapolated at the different running speeds would give us better guidance than just would be expert opinion for establishing joint-specific criteria for ensuring that our patients are safe to run. And so the next portion of this conversation will focus on the hip and then the ankle respectively.